These are the extraoral radiographic techniques: the postero-anterior skull, postero-anterior mandible view, Waters view, Sub-mentovertex view, jug handle view, reverse Towne's projection, and TMJ views. Today, except TMJ views, we are going to discuss all the other extraoral radiographic techniques. PA skull, postero-anterior skull view. So, for every projection for extraoral technique, three are important. First one is film placement, the second one is position of the patient, and third one is the direction of the central ray. These three are very important for every extraoral radiographic techniques. First, discuss about the film placement in the case of postero-anterior skull view. Here, the film is placed perpendicular to the floor in a cassette holding device. The long axis of the cassette is positioned vertically. Regarding the position of the patient, the sagittal plane should be vertical and perpendicular to the film, and head is tipped towards downwards so that the forehead and the nose touches the film, and the film is adjusted so that the lips are centered to the film. This is about the patient position, and patient should not move during the exposure. And the last thing is the direction of the central ray. The X-ray beam comes from the tube head, and the position of the central ray is directed at right angles to the film through the mid-sagittal plane through the occiput. The occiput area is very important here. The central ray should pass through the occiput region. So that is about the postero-anterior skull view. Let us discuss about the indications of the skull view, where we are supposed to take this postero-anterior skull view. Indications. It's mainly used to survey the skull wall, primarily the facial bones, for the evidence of trauma, disease, or any developmental abnormality. For example, the fractures of the skull wall, the investigations to examine the frontal sinuses, and the conditions affecting the cranium, where the size of the cranium may be increased in the conditions like Paget's disease, multiple myeloma, and the endocrine disorders like hyperparathyroidism, and sometimes we can see the intracranial calcifications in the cranial vault. So that is about the indications of postero-anterior skull view. The next view is anterior mandible view. So let us discuss the film placement in this view first. The film placement is almost same like a PA skull. Here the film is placed perpendicular to the floor in a cassette holding device. The long axis of the cassette is positioned vertically. The position of the patient is also same as the PA skull view. The sagittal plane should be vertical and should be perpendicular to the film cassette. The head is tipped downwards so that the forehead and the nose touches the film. The film is adjusted so that the lips are centered to the film. So up to here, the position of the patient and the first thing what the film placement is exactly same as to that of postero-anterior view of the skull. Only the difference is the direction of the central ray is different. The central ray is directed at right angles to the film through the mid-sagittal plane, through the cervical spine at the level of angles of the mandible. This is the difference between the PA skull and the PA mandible. In the case of PA skull, the direction of the central ray, it passes through the occiput. But here the central ray passes through the level of the cervical spine at the level of angle of the mandible. So that is about the central ray, position of the central ray in the case of PA mandible. So let us see about the indications of this PA mandible. The PA mandible, what are the indications are? The postero-anterior projection of the mandibular body and the ramus. The central part of the body is not well seen, mainly because of the superimposition of the cervical spine. It is used to study the fractures of the mandible at the angle region, ramus region, lower condylar neck region, nothing but a subcondylar fractures, the mediolateral expansion of the posterior third of the body, or the rami. In the case of tumors are cystic lesions and maxillofacial deformities, mandibular hypoplasia or hyperplasia. And these are the indications of postero-anterior mandibular view. The third is sub-mentovertex view. Here, just go through the nomenclature. This is mainly based upon the direction of the central ray. Sub-mentovertex view. Sub, below, mental, below the chin, vertex, what is the top of the head. That means what the central ray passes from below the chin region and exits from the vertex region. Hence, it is called sub-mentovertex view. So let us see about the film placement in the sub-mentovertex view. The film is placed perpendicular to the floor in a cassette holding device. The long axis of the cassette is positioned horizontally. Next comes, so this is about the sub-mentovertex view. See here, there how the film is placed. The cassette is perpendicular to the floor and placed vertically to the floor. The head position is tipped backwards and should touch the cassette. The Frankfurt plane is exactly perpendicular to the floor here. The beam alignment or the direction of the central ray is passed from the head and the cassette. That is, see here, as it is passing from the mental region and exit towards the vertex region, hence it is called sub-mentovertex view. So let us see indications of the sub-mentovertex view. It's a little bit difficult for the patient to take this view. The full axial view of the base of the cranium showing a symmetrical projection of the petrosals, mastoid process, foramen ovale, foramen spinosum, canals, carotid canals, sphenoid sinuses, mandible, maxillary sinus, nasal septum, and odontoid process of the atlas, axial inclination of the mandibular canals. These are the indications of sub-mentovertex view. It also helps in to study the expansile and destructive lesions of the palate, the sphenoid sinus. Next one is the jug handle view. It's a variant of sub-mentovertex view. Here the exposure is reduced approximately 1/3 to the normal exposure time for sub-mentovertex view. And this view shows a clear symmetrical axial view of zygomatic arches. That means what? Exclusively to study the fractures of the zygomatic arch bilaterally. And this view is very much helpful. It's a variant of sub-mentovertex view, as the zygomatic arches looks like a handles of a jug. It is called jug handle view. It's a variant of sub-mentovertex view. When an exposure is reduced to 1/3 of the normal sub-mentovertex view, we can call it as jug handle view. Next is reverse Towne's view. Here, normally Towne's means when a person sees a little bit upwards, it's called as a Towne's view. It's a reverse to Towne's view. It's opposite to Towne's view. The patient should see downwards. Here the patient position, the position of the patient is same as that of the posterior mandible, only the patient is asked to open the mouth. So that means what? The patient position already we have discussed. That is why the patient should bend his head so that the forehead and the nose should touch the film cassette. Okay, almost it should be centered towards the lips. So everything is same as the posterior anterior skull and posterior anterior mandible patient position. But here the patient is supposed to open his mouth wide. And here the central ray is directed mid-sagittally at the level of the mandible and is perpendicular to the film. So that is about the reverse Towne's view. Next, the indications of river stones. This view is for viewing the condyle neck, condyle head, high fractures of the condyle, intracapsular fractures of the TMJ, the quality of the articular surfaces, condylar hypoplasia or hypertrophy. So that is about the extraoral radiographic techniques. What we have discussed exclusively for the mandible except the TMJ views. The TMJ views will be discussed in a separate class. Thank you.